people often wonder about what we do relative to a health information exchange organization. And so the best way to think about us, if the metaphor takes, is that we're a social network for healthcare that is built on an analytics platform, and it's really focused on high-risk individuals. So if you think about a health information exchange, that's really about having data about all of your patients, right? We're really about trying to draw your attention to your really high-risk patients that are hitting emergency departments and hitting, because of the spread of our network throughout California, which also will go, not just hitting emergency departments here in Los Angeles County, but in places like Orange and San Bernardino and Riverside. We're hopefully cracking Ventura soon. Or actually, we have Venice Simi Valley over in Simi Valley. So, and then using that kind of knowledge that somebody is really in crisis and in trouble at the moment, to then be able to collaborate with the broader care continuum that includes hospitals, health plans. So we're really pleased to be able to talk to you about this today as a precursor to Debbie Rosen from Northeast Valley Health Center, really getting into the meat of her really wonderful case study. But with that, hopefully that framing helps for you to kind of understand a little bit of what we do at a high level. And now, Melissa, I'll let you take it away.
She was having some sound issues. Melissa, were you able to?
Hi, all. Yes. Can you hear me okay?
Yay! Yes, we can.
Good. So the other thing, I'm having some weird screen issues the last couple hours. Can you see me flip through the slides, or is it just on the one slide?
It's just on the one slide.
Okay. What about now? Can you see that?
Now
Can you switch over now?
Yep. It's
okay,
moving.
Perfect. Yeah, I think something with my display. So thank you, Sunil, for the warm intro. We went over a bit of this slide, but looking forward to talk to you all about clinics and FQHC, a bit of the workflow that we've been seeing. So I'll skip through a couple of these again, as Sunil framed it so nicely, that our roots are in the emergency department, but as you can tell from our nice bubble slide, we really have developed and evolved to a platform to fit the needs of so many different systems. So I'm an LCSW, like you said, and so I also talk a lot about needs assessments and, what are the needs of the community, what are the needs of the different systems, and I think that we really represent this very well because, again, the needs of the post-acute center might be very different than the needs of the emergency department, and so having different functionality for each of those systems is really great. A brief overview on our network. Again, about 126 hospitals live in our network, more in the queue to onboard. One of the important things that we were able to work with our development and products team this year was identifying a solution for our homelessness SB 1152 legislation that got passed. And so we had a lot more hospitals and a lot more clinics that have come on board because of this. So it's been really exciting to be a part of that within our California team. In terms of behavioral health and primary care, again, over 30 organizations, clinics live are in contracting primarily down south and up in the Bay Area. So we've done extensive work, again, with both of these large areas. In terms of the platforms and benefits, again, a lot of our use cases are related to three different things. Receiving real-time notifications when high-risk or at-risk patients visit an emergency room. I get a lot of questions on how we send these alerts or notifications. In some systems, they're integrated into the EHR within the clinic setting, and we are able to do direct messaging, so dropping this alert or notification in your inbox, or even via email or text, and it doesn't contain any PHI. It's just a link that opens up into our platform that I will show you in a bit. The second is really leveraging information for a deeper understanding about these patients that have high psychosocial needs, again, substance use, behavioral health, all of these things that are related to patients' high utilization. And then lastly, leveraging our collaborative features and using Care Insights. So I know a few of you on the line have been on a couple of the meetings that I've hosted in the last few months about the collaboration piece within the state. So having those ACOs and health plans, clinics and hospital clinical folks on the line to talk about how to share information with one another using our platform. That again, I'll showcase in just a minute. In terms of data sourcing, aggregation, and matching analytics, I'll go through this very quickly. Again, I know that we're pressed for time. So again, the way that this works is being able to connect all of you, like we saw in that initial bubble slide, and really being able to have you collaborate and coordinate care with one another. Again, we talked about the notifications, and actually I'm going to go to this next slide that shows this is just a sample notification of what, again, the hospitals, the ACOs, the health plans, the FQHCs, behavioral health is able to see and view. This is so groundbreaking because, again, a lot of the information, it's not just a repository, it's not just transactional information, it's really that information that has been added from individual users that can be helpful to everyone across the care continuum. So you can see just a couple of these to flag. We're able to identify care providers, physicians, nurses, social workers, resources that a patient has already been linked to. What we're able to match, we're able to query the NPI system. It's just seeing which of those physicians, again, or providers that a patient is linked to. You can actually even manually add those in there as well. All of these, the next section there shows the ED care guidelines. And so these are recommendations. These are just bullet points that are really important that someone, again, has gone in and added within our system that can be shared across all of those different health systems. Security events. So in the hospital world, we talk a lot about workplace violence, and so there's even a field where you can add that information. PDMP or CURES in California, the CURES data, those systems are able to also see when a patient has been prescribed high-risk medications in a specific time limit, or if you have a benzodiazepine and a narcotic in the last 6 months, it's able to push that information into the notifications. And again, one of the most used and most widely pieces that folks are excited about are the recent visit summary and the total ED count of where the patient has been in the last month. So I'm going to switch. Yep, go ahead.
We generally generate a notification within seconds, within minutes of when a patient registers in an emergency department. So if one of Debbie Rosen's patients registers over at Sentinel, she'll know in about 2 to 5 minutes. Or at California Hospital Medical Center, or UCLA.
And it does have the progress note on the alert?
No, it does not. We're capturing things that come off the admission, discharge, and transfer feed.
Yeah.
We are now making our initial foray into continuity of care documents, CCDs via care quality, and being able to better parse and map that data into, because we're not really, again, we're not an HIE, so we don't want to give you everything from a CCD. You should go to your HIE for that. What you should come to us for is for intelligence that's distilled from the ADT and the CCD that's going to be relevant about that and really actionable in the moment.
Okay, can you all see my screen, the demo screen?
Yes.
Of our platform? Okay, perfect. So, so one of the things that I think is really important to note is that just like that notification, that one pager that we saw, all of that information can be viewed within our portal in the patient overview page. So one of the important parts of what we're seeing here in this dashboard view are the specific risk criteria that in the Virginia Family Clinic demo environment they've chosen. So some important things here that can be added are if a patient on that clinic's panel has an ED discharge or an inpatient admission or an inpatient discharge. For transitions of care, we know that this can be really important. Anyone with a 15-day readmit, it looks like, again, any patient that has had any ED visits, and we're looking at a 24-hour view right now. So again, I can click on any of these patients. I can see who they are, their MRN, their gender, their age, the location, so which hospital they visited. Like Sunil said, maybe this patient went to California Hospital, this patient went to Good Sam, this other one went to St. John's in Santa Monica, et cetera. So if I click open Patricia Young, what I see here is this overview page that I was saying that is essentially a mirror of that notification, that one page. It shows a bit more detail here than you're going to get on the alert. But again, some of the really important pieces that are so great to have is if I click on her phone number, I can see all of the different phone numbers that Patricia has provided to all of these different entities or systems. Same thing with their address. So when someone is having a hard time finding this patient, or maybe the most accurate phone number, or the most recent phone number, you can go in here and see. This care team section below is what we were talking about. We're querying against the NPI system, but also we can manually add those providers in here. So you can see that Patricia's connected to a case management nurse, an internal medicine doc, a radiologist, etc. If I keep scrolling down, on the right side, I see the total count of ED visits that she's had in a year. And so a lot of times we'll see patients in LA that have 100 visits, 200 visits. So they're walking into EDs and out of EDs to, a lot of times using them as primary care because they don't know that they have a PCP. They have no idea that they're linked to someone through the health plan. On this section here, we can see more of these encounters in a smaller or a larger window. So I can go look at 12 months of data, or I can go down to 1 month. I can see, again, the encounter date, the location, where it was, and what type. Was it an ED encounter? Was it an inpatient encounter? Maybe even an outpatient visit to a specialist. And I see the diagnoses and chief complaints. And again, all of this data is coming through the ADT feeds of the hospital. Whereas we see this data here below, this is what we talked about in terms of the collaborative piece, the insights piece, where I can see that a hospital, Ruby Valley, has written about the patient's care, talking about how they have a Medicaid case manager that they should reach out to. I was on a call earlier today with an entity that writes care insights that states that the patients are health home eligible, and to contact this person when the patient shows up into the emergency department. Again, you can see that the clinic also is able to write a bit of information from about her medications, about some DME, maybe even about their family support, again here, next of kin. So all of this to state, I know we're really brief on time, we're really short on time, but just wanting to showcase a bit of the functionality and how it's being used, again, within a variety of different of systems across the care continuum. So Neil, Kyle, anything else we want to add?
One thing I want to highlight before we hand it over to Debbie is that everything you scroll through, or everything Melissa scrolled through, approximately the top half of this patient page for Patricia Young is data-driven, right? This is data that we are automatically extracting from typically, or most typically, hospital EHR systems in the background. Everything you scroll down below is the social network piece, right? That's the piece where you're actually, care managers, care coordinators, variety of folks from around a care continuum in a community are contributing content because we've seen evidence that militates towards a better outcome. So to highlight that, in California, where we historically have not had a lot of primary care on the network, we've seen about an 8% reduction in ED utilization for patients with more than between 10 and 20 ED visits who have some sort of content that has been written for them in our system. In Oregon, where we do have a really mature network with a lot of primary care and behavioral health on the network, you get a 15% reduction, right? So you do twice as well when primary care is actually, because it's also a tool for you to bring, hopefully some of these patients, a lot of these patients are complex patients who are currently disassociated from your practice, right? So there's going to be a step where you're using the current contact information, hopefully kind of bring them in. And then there's the step where then once you've brought them in, or whether they're established and still going to do care a lot, it's giving you the opportunity to communicate back to the hospital, like this is what you need to do, including, particularly if you're doing a health homes, your CBCME and your health homes, like bring them back to us. And we were on the line, I don't want to go too much longer because I know we want to give Debbie plenty of their time. We were on the line with Health Right 360 in San Francisco this morning, and they've been using us for health homes for over a year. And one of the things they do is they are able to tell hospitals, this person is a health homes eligible person, please call us if they show up in your facility. And when we asked them this morning, do people actually do that? And they go, yeah, they do. People actually call us around our eligible patients, and we're able to kind of we go get them in the ED. So anyway, with that.
Yeah, we're actually in conversation, it's Debbie Rosen. We're in conversation with one hospital so far about, I mean, it sounds great to just go into the ED, but you got to get permission to do that. And but they're very interested. Valley Press, we've been talking to them, and they're really interested and having one of our patient navigators actually go to the ED and meet the patient right there. Some of them are quite challenging to meet, so we're really looking forward to moving in that direction.
Thank you.
Thank you.
Thank you so much, Melissa. So, who is running the
Ray Pedden from CCI, Center of Care Innovation.
Okay, great.
Woo! Great. All right, so I'm just going to start and tell Ray to change the slide. So Deborah Rosen, Director of Quality and Health Education from Northeast Valley. And next slide. So most of you in this room know who we are, but there are others on the phone, so I just put the information slide. So we're federally qualified health center, PCMH recognized by Joint Commission. We are in SPA 2, San Fernando and Santa Clarita Valleys. We have 15 licensed health centers, 2 under construction, 1 mobile unit, 4 dental, and 13 WIC sites. In 2018, about 326,000 plus visits, and almost 76,000 users, 84% Latino, and most everybody under federal poverty level. We are, this used to be much different, but we are about even between pediatric and adults now, as you know, changed over the years with health reform, but we still have 19% uninsured. Next slide, Ray. So jumping right in, our initial work has been with asthma. We decided to work with patients who are hitting the ED with either a diagnosis of asthma or signs and symptoms of asthma. And so, of course, like most of our organizations, prior to using collective medical, we really didn't know when a patient would hit the ED with these symptoms. And we may never know that a patient sought care in the ED. So our patient might call to schedule a follow-up visit, maybe or maybe not. They might share that information the next time they come in to see their PCP. Or we might receive a CCD sent through Health Information Exchange that might go directly into the patient's chart with or without notification. So lots of challenges to know what's happening out there. So next slide, please. So we also know, no surprise to any of you, and it's not just asthma or asthma patients with asthma-like symptoms, that many of our patients seek non-emergency care at emergency departments. And for our patients, like many Medi-Cal patients, they're dealing with lots of social determinants as well, working multiple jobs, child care, transportation issues, so often it is difficult. And also sometimes, of course, access issues, getting into a visit when they want to be seen. So for many of these patients, the ED, unfortunately, is a good option for regular care for them in their perspective. 24/7 access, no financial deterrence, no copays, you know the story. And our patients don't fully understand when they seek emergency care that they lose out on the benefits of continuity care when they're coming to their PCP. And then they also either don't know or don't take advantage of the after callers. We always have access to a provider after hours, but many do not use that. So there is definitely a lack of continuity when patients seek both emergency and non-emergency care in the ED. Next slide. So with collective medical notifications, and I was just on my phone kind of looking to see what I got today already, because I am the proud receiver of notifications from collective medical. I was having a lot of stress during flu season, seeing how many were coming in on weekends. I'll talk about that in a minute. But I do get notifications on my phone at all hours of the day. I don't look at them at all hours of the day. They are coming in, and we've decided to as I said, start with asthma, patients with a diagnosis of asthma or asthma-like symptoms. We are also receiving now notifications for patients who are hitting the ED and inpatient for diabetes. And I receive alerts for patients who are considered our high flyers, and we decided on what that definition is, and there's about 80 in that group. So yes, today I've had 3 asthma patients hit the ED, 1 diabetic, and then more. Yesterday there was 1 high flyer, and we'll show you the next slide and tell you what we do about that. So once I click on my alert, it brings me to a screen like this, and then I hit the, I'm not the IT person. The link, thank you. I just had a brain freeze. It happens all the time. You don't have to be IT to know that.
So to clarify, you're getting your initial notification by email, but there's no PHI.
Exactly, right. In fact, so I click on the link, and then I have to wait for a passcode. And so the passcode comes to me, and then you can open up, so it's very secure. And you can go to the next slide, Ray. And so this is my health educator who is using, so what, we'll talk about this in a little bit, but what you have to do is, of course, figure out, I'm not answering all of these alerts, I'm receiving them, but I have assigned individuals to be responsible for these alerts. So we have a health educator who focuses on asthma, and she's responsible for receiving and managing the alerts for asthma. Now, I have different people that are managing these different alerts. I'm just receiving them all to see what's going on. So this was a quote from her. She definitely sees this as a useful tool to see who's in the ED, really learn about, in particular, about patients for many reasons, but patients who have never been seen by their assigned provider. And these are our pediatric patients. I don't think I said that originally, but this is just 0 to 17 with asthma and asthma-like visits. So we did not decide, mostly because we don't have as many resources for our adult asthma patients. So this was all around, well, who's going to manage this? No point in getting these alerts without doing something about it. So we have a much more robust program at Northeast Valley to manage kids with asthma symptoms. And so we did find, and we continue to find, patients who've never been seen, who are assigned to us and never been seen at Northeast Valley. And then as a result of that, we can, of course, provide education and support and connect them back to primary care and hopefully reduce their ED visits in the future. That is the goal. So next slide, please. Okay, so we received training in the last quarter of 2018. As I said, we decided to initially focus on our pediatric patients, and this was a important focus area. We think we can make impact, and we also had the structure of staff being able to manage this. So we worked with Collective Medical to establish what are the guidelines, keywords that they're seeing that will create this alert. And then we developed workflows. How are we going to respond to that alert? We let our providers and care team know what their responsibility is. So a health educator in my department initially manages, but then I'll talk about what her responsibility is. Our alerts began in December, and then we look at this data and see what we're receiving every month. We have an asthma QI meeting, and then there was a big jump, as you might imagine, during flu season, so that was particularly challenging. Although 3 today was kind of seems like a high. So next slide, please. You can't see the details here, but this really shares if the patient has asthma. We are alerting our 2 asthma care coordinators that work at Northeast Valley. They actually reach out to the patient directly, and it's documented in our medical record or our electronic health record. If they don't have asthma, it is going to the PCP, and the PCP asks their care team if they want to, if they need to reach out to them. So they make a decision about whether to reach out to them. And we're using provider test actions, so it's for next gen, it's documented in the medical record. We will also share chief complaint diagnosis, but also the history. I think, you already heard, you learn a lot from how many emergency department visits they've had in a certain period of time, if they're going to various locations. So that kind of gives you quite a picture of what's going on in that patient's life. And particularly if they're not, but both, if they're connected with Northeast Valley, if they haven't been seen for a while, if they've never been seen. So all of that information really helps you with decision making. Next slide, please. A lot of information. Okay, so as you already heard, we're receiving this real-time notification with the goal to reduce ED utilization, reduce readmissions, support that transition, and improve patient outcomes. So we're not getting reimbursed for this work, and personnel resources are needed to respond to this notification. So I think it is important that you identify staff in your organization who can handle this and work with the providers on what their responsibility is. So we did, with limited resources, we did not pay for collective medical, but we didn't receive any resources to staff support for this. Okay, so next slide. So what has happened so far between those dates, as you see, 12/18/2018 through August 8th, over 1,000 just for asthma and asthma-related symptoms. The number of pediatric patients with an asthma diagnosis, 172, 661 without an asthma diagnosis. So this would be up to your organization as to if you wanted to just limit it to asthma. You really have the ability to work with collective medical and make it broader. Just to jump a little bit with our work with diabetes, we started that in March of this year, and I wasn't getting anything, and so I opened it up a little bit, and we're receiving more notifications, and so you have to kind of test things out. A lot of provider test actions, they are so happy, but it's really important information. We are seeing a repeat visit, so we hope to see fewer of those, and 32 have never been seen at Northeast Valley. So we have a managed care department that reaches out specifically to patients who are members, non-users, and they're doing that outreach. So we refer those to that department. Next slide. So this is our asthma care coordinator, amazing. She is really one of the two individuals that are responsible to reach out to these patients. They both have a very strong relationship with a lot of these individuals. The patients are kind of shocked that, they're getting a response because we're managing this every day. So we're sending this to our care coordinators. They're reaching out to this patient, that day, the next day. It's pretty quick. And they know, we are aware that they went to the emergency room. But the idea there is that, we want to provide our families with self-management strategies to keep them out of the ED. We inform the families that they can call again. They can call, and they don't have to go to the ED. When the health center is closed, you have to keep reminding our patients that they can do that. And after the phone call, they often are reassured that in many cases they can help manage these symptoms and avoid the ED. So we think, this work is really, really valuable. Next slide. So challenges, I think we talked about it already. So staff has to do this work. Each one really doesn't take too long, but you have to have someone dedicated to that. So what happened during flu season? So when we started in December, flu season came out relatively late this year. December was quiet, and we were receiving about 1 to 3 alerts a day. It jumped to about 13 a day. So that was a big increase. So it impacted her workload. This is only a little piece of what she does. Also impacted the providers. We did decide to have it for asthma patients with a diagnosis of asthma and just patients with symptoms. Some of the providers said, just schedule them in. tell me, just schedule them in. And our medical director of pediatrics said they may not need to come in. So we don't just bring in patients, you know, unless they actually need to come in. So we pushed back a little bit and, you know, said, please reach out to them, your care team, and see how they're doing and see if they need to come in for a visit. So, and then we're still we're collecting a lot of data. We know, as I said, how many are repeats, how many have asthma, how many don't. We're still trying to figure out what's the necessary data to collect so that we can really streamline that, because a lot of that is an amazing person who's really keeping track of all these patients that she manages. Next slide. So lessons learned, consider your priorities. I think there's a lot of incredible opportunity here. I mean, I think there's a really opportunity to decrease ED visits in the future and really connect to those high-risk patients, really provide care management for these patients. I think that we need to continue evaluating what, you know, of course, with asthma, with ED visits, for asthma, it is cyclical. So we didn't do a control group. I don't have any comparison group. And of course, a lot of our patients were in the ED during the flu season. I am hoping to work with Collective Medical and do a comparison group of another organization with a similar population. So I can really look at, you know, 6 months before, how many ED visits did these patients have, 6 months after, to really do a good analysis. But I think it's extremely promising. So next slide. So already, again, I said evaluate the effectiveness of the intervention. I think where the return on investment is, besides providing excellent care for our patients, but reducing the cost of ED visits is critically important. We are now implementing the same process for our patients with diabetes. I have one person who is managing the alerts. And we at Northeast Valley have a care coordinator at each of our health centers that work with diabetic patients. So she sends that to in the electronic health record and tasks it to the care coordinator, who reaches out to those patients. And we have our high ED utilizers that are very complex, that visit the ED an incredibly large number of times. And then hopefully soon, we are going to be able to, we are a health homes provider. We hope to, even though that list changes every month, adds takes away, but we want, these patients are all in Collective Medical because they're managed care patients, but we want to be alerted when a health homes patient hits that ED so that we can actually get in the car and go see those patients and be aware of where they are, where they're seeking care. So our plan there is getting that list of health homes eligible patients into Collective Medical, getting the alerts, and in that case, we have patient navigators that are managing these patients and can reach out to the patient. So the next slide. Almost there. This is our medical director of pediatrics, and she's the one that decided that providers would still get all those alerts. She did share that at the height of flu season, some providers were reluctant to respond, but the utility of the alerts were that we could assess the patients and determine whether they needed follow-up care. So we're really providing the best care that we can, and we've been able to make full use of our asthma case management and health education staff to prevent future inappropriate ED visits and really connect them back to primary care. I think that's it. Yes. So open for questions. Thank you, Ray. Great job.
I have a quick question.
Yes.
Sorry. First, we're very grateful to be able to work with you. And I can also say that we have other, at least of the health centers that are represented in this room, I think we have pretty much everybody except for child care.
Oh.
Right. I didn't mean to put you on the spot.
Yeah.
So a lot of that has come through an engagement with Iris Weil and her team over at Healthcare LA and through network management. One question I have is, Why are you tagging your eligible patients as opposed to also your enrolled patients, your health homes enrolled patients?
Well, we should be doing that.
Okay.
Yeah, we have quite a few now. I think when we first started this discussion, it was to, yes, absolutely. So we want to tag, this is a moving target. So we have and Stephen can speak to this, in the EHR, we have alerts that say the patient is eligible, and which was automatically entered, but when they become enrolled, it's a manual process. So it's really a matter of working with, I'm looking at Stephen right here, being able to, because this list is changing constantly, and so being able to change that and update it. We're getting, we have a number of different health plans that we're enrolling patients in health homes. We're getting lists not at the same time, at different times of the month, and so, it's a moving target. So we have to figure out an easy way to upload the information and the enrollment. And also, patients who are no longer eligible or choose, we've already contacted, they choose not to be. There's a lot of moving pieces with health homes, but I think there's opportunity there.
I do have a question. So right now, the way that you initially piloted the use of this with Health IT was asthmatic patients, but now it's diabetic.
And high flyers.
And high flyers. I'm just curious, is it, are you able to get additional kind of elements, such as things around x-rays or labs, enough information so that there is kind of an appropriate level of follow-up?
So we do not provide, because that information does not come over the admission, discharge, and transfer fee. But that's where we see like a very complementary value proposition between us and a health information exchange organization, because we're sort of giving you, one of our key principles is that we're pushing things into your workflow, right? You can't go to our portal and query, but really it's about the fierce urgency of now and notifications that are helping you identify somebody who's in some sort of crisis. I don't know if flu is necessarily a crisis, but certainly if you're a high flyer, you're somebody who's had like more than 12 ET visits in the last year, probably in crisis, right? So so as I indicated earlier, we are starting to get into how we can better tap things like continuity of care documents that would have some of that information and give you things like progress notes, discharge notes, summaries, discharge summaries. But in the meantime, we have been historically very admission, discharge, and transfer fee focused. And so, it's really about kind of understanding key things that people put in the system, understanding their utilization characteristics and the diagnoses that would go along with that. And then you kind of go like, okay, I now have more of a basis for wanting to like dive into lanes if that's your HIE paradigm and find things like your labs and meds and your x-rays.
Thank you. Are you receiving case management? So there was a piece in the Eddie about case management. Are you seeing that within what the hospitals are providing and vice versa from what your staff are providing on to Eddie as well?
We haven't started on our end entering it, but that is the plan, and we definitely want to add in the Health Homes Patient Navigator that's associated with that patient. So please call us, name, telephone number. So our plan is to do that, and we do see some case management what's documented from the hospital.
I had a question about the care equality piece you mentioned. Is that something you're doing now, or are you planning to do this?
It's a guerrilla operation being run by our CIO, who's one of our founders, right? So this guy hoists the pirate flag, right? But he also runs a security operation that is more locked down than Fort Knox. So at any rate,
It's all over IT department.
So we did our initial contracts in partnership with Care Quality, and then Care Quality is also supposed to be linking up with Commonwealth, is my understanding.
I think they have already.
Right. So at this point, we are, it's all done. So we operate.
Like I said.
Right. So the way any individual provider access data through our system is either from a hospital is pretty strictly under the treatment and operations provisions of HIPAA, and then if you're an outpatient provider, the way you establish the relationship is in the hospital, the relationship is established because somebody registers in a TP, and that essentially is consent to treatment and share information. unless you opt out in some certain cases. At the health center level or the health plan level or the IPA, there was a little bit of a glitch in one of our slides. The way we do it is we get patient lists either from a health plan, from an IPA, or from a health center directly, right? And so then, okay, so that's how you're able to get access to that data. So we are starting to have, it's not available to health centers yet. We're going to want to set up a conversation. Our CIO and I actually had this conversation via Slack yesterday. We want to talk to you about the utility of certain things coming out of the CCD, right? So that's kind of the path we're going down with respect to, because right now we think through care quality. So nationally we have more than 700 hospitals nationally live on our network, including, as Melissa said, 125 live plus another 30 or so in our process in California. So, on a treatment payment and operations basis with the patient, we can then tap CCDs from care quality, and that accounts, I think, right now for 25% of American hospitals, right? Because it's a lot, principally Epic shops, right? And then I think, Cerner shops tend to work more with Commonwealth. And I think somebody provided us with a really excellent map of just the various.
I have an updated version I can send you.
Yeah, our CIO loved that, so we'd love to see it again.
Yeah.
Because it's very helpful to us.
Well, I was just thinking in regards to the diagram, I think it'd be helpful to list the hospital, like maybe putting something in there about who's on Eddie as well.
Yeah.
The ones that are on that list.
Okay.
Just because I know, like with Northeast Valley, they were using it in partnership with Care Quality, so you can see a patient in the ER and Eddie, and then you can see what happens with Care Quality.
And so that's going to be the thing is we can actually now tap CCDs from non-Eddie hospitals, or we now call ourselves a collective. So we can now get CCDs from non-Eddie hospitals because we can do it under TPO. Under HIPAA, we can get it for non-Eddie hospitals by care quality because that's why these were set up, right? Was to promote interoperability in a freer flow of information. At least in a way that's HIPAA compliant.
So I want to, okay.
So one of the things that we're having a challenge with health homes is for the homeless individuals or others that we can't reach because we don't know who they are and so forth.
Correct.
So we've been doing a lot of manual scrubbing and things like that. Will, this particular system allow us to know through their matching, to be able to upload the list of these patients and say, okay, how many of these belong to or have been seen in the emergency room or whatever other, venue, because it's really time consuming right now for us to do it. So are you looking for us to be able to identify your assigned all those patients who are homeless? Or are you saying that you upload lists of your homeless patients so that But so if I upload a list, will there be an automatic match or a potential match?
We do it externally.
So you pull it from Eddie, and then you get your list, and then you just do it in time.
Okay, so this is another right. So this is another conversation. So Sergio, what I'd like to do is I'll give you my information, and then I'd like to get your information because I'd like to have a conversation about this because we've been having a big push this year, as Melissa started to indicate earlier, to better support the identification of and collaboration around individuals who are experiencing homelessness, right? And there, you get into the definitional stuff like homelessness versus housing insecurity versus, and then people for whom homelessness is a transitional state, right? They're couch surfing or, so at any rate, the way we currently implement it in our platform is mainly hospital facing, in the sense that we can identify somebody who's homeless in our system. If a hospital manually uploads a homeless discharge plan, right? So if they've got something they developed on paper or something they developed in Epic or Cerner, they can scan a paper document, upload it as an attachment to our system, put it in a discharge destination. That marks somebody for about 6 months as homeless in our system. They can do they can download the homeless discharge plan that's developed in their EHR, again manually upload it to our system, put it in discharge destination. They can do it that way. We have special functionality within the collaboration tools that Melissa was showing to you called Homeless Insights. So if somebody enters a homeless insight, including discharge destination, third way that somebody is identified as someone is identified as homeless in our system. Fourth way is if a hospital is pushing a homeless discharge plan into a CCD, we can get a hospital to work with us to map that, and we can either get it through care quality or through a direct interface to the hospital. We can do it that way. So there you have 4 ways. We have other ways that we are looking to do because, among other things, the hospital associations are really interested in this information because they want to go back to the state and go, hey, this is how much of the homeless are costing, are hitting hospitals, right? And I can show you data on, we currently can identify, at least from an analytic, from a data science analytics, this is not built into our standard reporting yet, but we can run like reports where we currently identify people as suspected homeless based on their they're either using the hospital as their address or in a shelter. That's another way that we do it. And I asked the data science team to run a utilization analysis about the utilization of those individuals. It's mind-blowing. But like, we pulled up 9,000 people, and it's like they're going to, we identified 2,500 people who are getting admitted to the hospitals who also account for half of the PD utilization of the overall suspected. So we're identifying at least the characteristics now. So the reason I went through that whole thing is the next frontier we'd like to explore with you is, can you help us identify, can we use you as a data source to identify people as homeless, right? Because that's useful to everybody across our network, and it's useful from a population health management analytics perspective. I would think also for organizations like CCALAC. Does that make sense? We'd love to partner with you around this.
Well, I think you went way beyond what I was just asking.
Okay.
I just wanted a simple match.
A simple match. Okay. I apologize for that.
So
But I just heard it from Arnell that they do it externally.
Okay.
So they probably just get the list from Eddie
And download.
Yeah, download it, and they just.
Well, so the reason I did go because the reason I went on that is because we did speak with Healthcare 360 in San Francisco precisely about how they can start to identify, because they're the first primary care practice, or the first FQHC in California to do our homeless insights functionality will be made available. So,
Is that a medical cohort now?
no.
Homeless?
Yeah.
Gonna be?
That's what we want. That's where we want to go.
Okay.
Yeah.
Well, because I would assume that you want to talk to, the coordinated entry system, HIMSS, CHAMP, which are the 3 major, databases.
Right.
That would give you that information at a, very simply, good luck trying to get it, but, at least those are the 3 sources that you would definitely do that. Because they're the ones that all the homeless agencies work through, or other agencies that provide homeless services.
Sure.
And they identify all these individuals. Obviously, Northeast Valley has probably one of the largest grants for homeless.
Well, we
We get one from here. So
we're the lead agency, yes.
So, they have a list because we report all our data,
Right.
to them. So that's another one that does, in the blink of an eye, you can populate your data and very simply.
Okay, so that sounds like another thing we can work on.
I mean, so just from our organization, we can identify, it may not be totally accurate, but we can identify homeless patients. And that's what we're doing with our idea for Health Homes Eligible, is that we are uploading that. That's the plan, is to upload it to Collective Medical so we can specifically get alerts on that population. That's the simplest.
Yeah, because that's the biggest barrier that we're finding right now.
Yeah.
Is that we get the list and so forth, and we try to reach out to them,
Right.
but without having a picture and not knowing where they went last time,
Yeah.
it becomes impossible.
I know.
So we're relying on at least the local homeless groups to say, okay, this list of patients, if you see them,
Right.
or do they sound familiar, and they'll go like, oh yeah, so comes here every day for food, or comes here
A
for
place to sleep.
for sleep and so forth, and then we're able to connect them.
Yep.
Uh,
There's one other use that I'm really excited about. We're using the Enrollment Manager and identifying patients who are members and had never been seen. And so our plan is also to upload that list, so identify those patients who've never walked through the door and be able to reach out to them. So there's just a lot of opportunities.
I'm curious with regards to matching within Eddie, and there is a disconnect between patient records from the PCP and patient records at the hospital. So I'm curious how well that matching does take place, and identifying the patient being the same individual but potentially different variants of the same person in terms of name.
So for once, I'll give a relatively simple answer. So what we do is we have a matching algorithm that we believe is about 99. What's the number, Kyle? It's like 99.794% accurate based on our own. I mean, it's our own analysis, right? So
We think it's good enough.
yeah. Okay.
And I was, had to remind myself, so I was looking for a patient who had been, I had gotten alert for a couple of months ago, no longer found them in collective medical, and that's because they weren't a managed care patient anymore. So this is strictly, and I think that's being updated by, I guess it's Healthcare LA, or working with collective medical. I'm not sure who's responsible for updating that list, but you are only seeing your patients that are enrolled. So.
Yeah, so I talked to Allison, was it yesterday, Wednesday? Thursday, I think. What, today is Thursday?
Today is Thursday.
Yesterday, about this, because the challenges that we're facing with, being the July 1st integrators of health homes.
Yeah.
I was saying, you guys have all this data, whether it be emergency room, claims data, all these things you guys have, why is it that you guys are not sending them the information to find out? It's an easier sell than it is for me to, and all the FQs to go out and try to match all these patients. She was like, yeah, you know what, we've been talking internally about that. And I go like, well, I think you have the Eddie project, you have all these other projects that you guys are doing to, forward all that information. Why don't you just give us that information? When was the last time they were in the ER? Simple as that would be a good thing. Or how many times have they gone somewhere? That would be helpful. But again, so she's going to take it back to LA Care and find out if that's going to be possible.
So it's Allison Crystal from right there.
I think weren't they giving you guys the ADTC in Excel?
Yeah, but the same value as getting our rosters for just normal.
This is Excel.
Well, it's not the Excel is not the problem, it's the data.
The data's
No.
It's old, phone numbers are wrong, so all of that thing. So that's the biggest issue, so we need, something that's near real time, whether it be Eddie or whether it be another source to be able to really go against it.
Speaking of data analytic skills.
Okay, and the reason being I was talking to Susan from Corporation for Support Housing, and their big push is making sure that through health homes that the homeless individuals are getting services. Well, it's going to be very disappointing because we can't find them. Okay, so out of the, I think we now have 75. Out of those who are as far as homeless, we only have 2. And so if you look at it, if the numbers continue to be the same, that's going to be very disappointing for a corporation for support housing, the homeless groups and so forth. And that's why I was saying we need to be able to get data from, the coordinated entry system and the other systems in order for us to at least try to see when is the last time anyone did an assessment.
It's what?
No,
Compare,
they would have to come in.
to assess.
Yes,
But they'd still have to come in.
So one thing I do want to,
So I've got a different question a little bit. You mentioned the consent, and I'm curious about that, where it's sort of an opt-out, you've already addressed this with your product, but we're also now working with Lane. Lane has presented a completely opposite viewpoint of consent. and saying that we have to physically get signature consent from the patient, and that's an opt-in. But, so how, can you sort of talk to that? I'm not sure which.
No wonder Lane's is going to like 3 weeks number, isn't it?
Like, we're not gonna do that.
Nobody does
Right,
that.
Yeah, that's,
They were very adamant about,
I
you have to have them physically signed. Now, interesting enough, you're giving us data, so technically, we don't have to get the consent, the hospital would have to get consent to release it to us, but I'm still, as we talk about the TPO, consent, I'm confused now, which is the right
right.
thing, so can you address that at all?
Well, remember that in the land of law and regulation, there's never one right answer. There's only what ultimately is defensible in a court of law if it comes to that, right? Luckily, we have not been in that situation. So we have created, one of the foundational elements of our company is a national data governance framework that is based in treatment payment and operations division of HIPAA. So again, just to restate, our position, which has been accepted by everybody, certainly all the hospitals that subscribe to our network, with some exceptions. So in certain cases, Kyle, you can check me on this. We do have certain hospitals where it's more of an opt-in model, and if somebody doesn't opt in, then basically we have to filter out that patient, right? So it's not perfect. Kyle, are you there? Kyle Uribe is he's actually on the health plan side, but so a colleague of Melissa on mine who's listening into, or thought was listening into.
He's on the call, but is muted, so.
So I don't know how Kyle could be unmuted. So
I think he has to do it.
Oh, okay. I think I
There you
unmuted
go.
it. Did that work?
Yes.
I was talking. It didn't work. Yeah, so Methodist Hospital actually is one of those that has a different interpretation, and they've taken the approach of, they make sure that every patient has the option to opt out or opt in as they're going through their visits. It's initially a lot more restrictive, but the irony of this, of our general counsel and I were actually having a conversation about this a while back. New York State has a very strict, by default, everybody is opted out. You have to have an opt-in process in order to share any kind of information. And the ironic thing that has come out of that, the unintended consequence, is that patients are opted into everything as a blanket statement because every practice, every provider has a form to opt them into everything in order to even treat them. And so it's kind of gone to the other extreme, whereas California, almost every hospital that I've dealt with with the exception of one, has taken the interpretation that by default patients are opted in unless they opt out. And many of them don't even have an opt-out process in place. They do it kind of by request, essentially. But some of them, like UCLA, they have a lot of, I guess what you could say, special cases where, famous people or things like that, or donors that they will opt out automatically, as well as, those that have filled out a particular form to opt out. So just a few different options and ways things have been interpreted.
So the one place where we do require explicit consent is with respect to sharing of what's defined as sensitive information, right? Substance use, psychotherapy notes, other mental health information, genetic information, HIV test information. So, where we particularly focused our consent model, it was initially with outpatient medication-assisted treatment providers. So there is a way for that kind of organization. So if you have even providers within FQHC, they'd have to be on their own instantiation of the collective portal, right? Because you'd have to have segmented access just for those patients. But if you get consent for that patient, then their information about their treatment can't be shared broadly across our network. So if the use case is you've got somebody who's under treatment, medication-assisted treatment for an opioid use disorder, and for whatever reason they go to a hospital, probably good for the hospital to know that, right? So that's the utility of an outpatient provider getting consent. So that's where we do require explicit consent.
I have a question about Eddie. This is a web-based portal, correct? Not something living within EHR.
Well, that's a good question. Yeah, with respect to when you're going in to kind of do the deeper dive, So when you get a notification and you're in a primary care setting, because typically, as often, we're most frequently doing that by a non-PHI email. So then you click into our portal. We'd like to figure out how to implement single sign-on for you so you have a better user experience.
We have it.
Okay, yeah, you have it. So,
Single sign-up. With the collective medical.
yeah, they have single sign-on. So they can just click on that and they go into the portal. But yeah, that, because of the nature of the information we're aggregating, it doesn't look within the EHR.
I've done it before.
You do it yourself.
Separate
We
website.
have our own single
So you don't have to wait for a passcode to come down, is that what you're saying?
No.
Okay, well, it's pretty fast now.
It's fast.
It's always in our junk email, but it's fast. I know where to look for it.
It's a way to have that channel to different message inboxes,
Yeah.
that type of thing too. It doesn't get lost in the junk mail. Fun it.
Yeah.
Great. Are there any additional questions or?
Are there questions?
That's on the monthly.
Yeah, are there any questions on the phone? I'm thinking that most of these people are with your org, actually. I know Mika's there.
There are two of us. Two
Oh,
of us,
okay.
first probably right having.
Right.
Okay.
So I'll throw out, since you've got time a little bit, for those that don't already have it and use this, just to, as we talked, it's a notification system that the patient has been, just admitted or just registered at a facility. The CCD that's coming back, is the information and content is going to be, the timing is going to be how soon that the facility puts the information in. I think we originally saw that, they're in the ED, but that CCD, you could actually pull one. It has nothing on it but the registration information. And it takes sometimes, the emergency room, Debbie, you could talk to this better than I can, but it may take them 2 days to get around to putting all the information. They don't chart. You can see the nuances of how even individual providers probably practice it, charting. You have to wait sometimes days for that CCD to actually have enough information to use it as a care document.
Yeah, but so for the case of asthma or asthma-related symptoms, you actually don't. For this case, you don't need that much. You know what their chief complaint is, their diagnosis, and you just want to reach out to them quickly, see if they need to come back into primary care. So
but
that's
the discussion with the CCDs, I wanted to sort of make sure everybody knows it's really not a usable document for this purpose. You just need to.
But we're hoping they expand that data set.
Yes.
Yeah. So hopefully it'll.
Think low birth weights.
They have scheduled, and they come in. You've now got a more comprehensive document.
Yeah.
This is great. In the state of North Carolina, we were working with Epic Clinics. There was a community portal that the health center was utilizing. This is way more useful, I feel. It's definitely timely, and I feel like it has a better user interface to be able to communicate. I think I do recognize that social network platform to it, because that's more meaningful, I think, than going through a list of records.
Yeah, and I think we always get a question, are you guys like Epic? Do you just care everywhere? Are you like Lanes? And that's why we kind of finally said, let's try out telling people or saying to people we're a social network built on an analytics platform, because kind of what we're trying to do is act as connective tissue within, certainly the healthcare system, and then to the degree that, we can manage this over time within the health and social services systems, right? Because we're just trying to give everybody a way to kind of identify who's who's really in crisis, and how do you collaborate on that? So I don't know if we're about ready to close out, but a couple of
We
things.
have about 10 more minutes.
Yeah, so a couple of things I can add is most of your teams probably should already know about this, but we are doing, I think I can disclose that we have in fact, as one of our slides said, we have signed with LA Care, at least for an initial period, to support their Health Homes initiative here in Los Angeles.
Kind of question.
Or to be one of the organizations supporting their Health Homes initiative here in Los Angeles.
That's great.
Particularly with respect to how we're, again, helping you identify your high-risk Health Homes eligible members, because those are the people you're looking for ways to get them engaged. And then the bonus is we can get you collaborating around them. So we are going to be having a meeting at LA Care from 11 to 1 on Tuesday, Tuesday, October 22nd, many of your teams, I know Debbie, I know you've got an invite for this. This may have gone more over to like the people we have in our system who are more in sort of care coordination, case management, medical directors, those kind of folks. Because really what we're going to do is, we originally had commissioned this, had designed this meeting to meet the needs of Iris while in terms of getting people really trained up on how to both use the content, the social networking parts of our platform. And so now we're also harnessing so that we can help you really generate an outcome, right? Have a real impact on utilization. Now that we have the LA Care dimension to it, is we also that can also apply to health homes. So the title of the meeting is Collaborative Mindset, and then we're really it's going to be a mixture of making sure people are well versed in the platform, but that they're also getting trained on how to use those social networking kind of capabilities. So I think, like I say, most of your team should already have information about that. But can we put our contact information back up?
Yeah, I think.
Someone over there will have to grab it.
You can circulate our contact information.
I can circulate it out, whichever name you want, if it's yours or.
Yeah, it can be just, I'll get, Kyle's doing a lot of it. Kyle, Melissa.
Yeah, I can add all of them.
Great.
But would you also have information about that meeting that I'd be able to distribute to the group, or is it very
Sure.
specific people? Okay.
Yeah. And we're definitely encouraging health centers that are doing health homes work to definitely participate if they can. It will be both in person at LA Care on Tuesday, and then we will be webcasting it as well.
And you said that's 11 to 1?
11 to 1.
And I think I may have that email. It was sent internally.
Yeah.
Folks on the health home distribution list. I could probably share that with you all.
Okay.
But
So one of the things I think we haven't talked about, and I think when we were talking with Iris and seeing Eddie and so forth. So right now, what is the cost? Because I think when we're talking with the IPA, I never really got a good sense, even when I saw the data.
Yeah. So typically, the way that we support health centers is we will not directly charge a health center, but we like to know that there's a risk-bearing entity that is sponsoring you onto the network. Does that make sense? Because
in this case, since Iris is the one that brought us to it, so it's the IPA that's paying for this.
you're going to be covered. You're going to be covered both between Healthcare LA and LA Care.
Okay.
It's pretty so do.
Yeah.
Do it.
Well, nothing
what you said there.
Nothing. The reason why.
Hold on one second, Kyle.
There's another dimension of our needs.
Yeah.
That has been met through another software.
Okay.
So, I just had to decide,
Okay.
what it was, so that's the whole thing.
Okay. Kyle, what were you going to say?
Yeah, I was just going to let Debbie know that if she wants to increase the population in her portal, I just need a file, and we can get that processed. And if you want to do your entire population, we can absolutely do that. We're already working with some other organizations to add their health homes population, just so that we're getting the file straight from the clinic. And if you wanted to add your fee-for-service patients, we can definitely do that. It's generally a good idea to know if you're adding patients for whom you have some sort of a risk-bearing agreement. Then I just need to flag that for Sunil. But other than that, fee-for-service you can absolutely add, as well as your health homes patients, because those are definitely sponsored.
Yeah, I mean,
So the health homes
because we didn't
are in there already.
earlier is that we were founded by an
Are all of your health homes patients part of the Healthcare LA population, though?
Yes,
They are.
yes, so they're
Okay,
already,
that's one thing
they're already in there.
Because you're getting the Healthcare LA.
Okay.
There are multiple layers in that. Okay.
Yeah.
So you
Then it's just a matter of getting a file to identify which ones are specifically part of the health homes population.
Exactly,
So that we can set up a different workflow for those, right?
exactly, yes,
So you guys are not working with the
Okay.
other.
yes, we are.
I have a quick question. This
If
is
you guys
Sandra.
have both.
This is Sandra from St. John.
Hey, Sandra.
Oh, sorry. I just had a quick question. As far as identifying those patients, like for health homes, can that be separate completely, or do you have to have like all the LA healthcare LA patients in combination?
Good question. We can play it. We'd like to have as much as we'd like to have a standard scenario, we can play it any number of different ways. One of the things we talked about the other day is that, because we were just thinking through all the complexities of multiple payers on health homes who are not necessarily, because health homes is not associated with healthcare LA. And what I've always worried about, so just to be able to give you some more background, I did a couple of years as Chief Strategy Officer for the network of FQHCs in Alameda County. And the delegation matrices here in LA County are just like, and so you can get into a lot of potential messiness. So one of the things we talked about the other day is that there is a scenario in which we will suggest that one of the, perhaps the best ways to interact with us from a file perspective is for each organization to give us all of its population rather than relying on anybody else to give the population and then doing supplemental files to mark these people as health homes, right? It may just be more efficient and more effective for everybody just to give us their files.
I don't know about efficient, but yeah, our plan was that we would get the files from each of the plans that we're working with and put them together and upload that list.
Plan.
That's the plan, yeah. But
How many payers are you working with for health homes? Four? So LA Care, Health Net, I'm guessing?
Molina, right.
LA Care, Health Net, I'm sorry, Blue Cross Blue Shield.
Okay.
Yeah, and not Molina.
I have one more question. So if you're going to be getting information from Care Quality with TC data, are you putting information into Care Quality as well? So if our health centers are connected to Care Quality, could they get some of the PCTCs through that? Because the reason why I'm asking is because Care Quality is embedded in the EHR. So they don't have to go out of their EHR to get information, which is why that has been sort of
So the question again is, will we be putting information in?
right.
No, because remember, well, let me qualify that. Is there a scenario because remember that none of the data in our system is unique to us, right? We're just the way from a data and analytics perspective, we're just aggregating data from other sources.
Okay.
Now, is there a scenario sometime in the future where the care plan content that's written into our system becomes, because the problem is it's not discrete data, right? There's a lot of care plan content is discrete data. But anyway, the point is could we see a scenario in which the care plan content that's generated uniquely in our system is exported to Care Quality? I will say possibly or probably. It's just something we will need to explore.
Okay.
I'm sorry, I just need to run.
Okay.
Just because I need to start getting towards the over because I need to get back to Santa Cruz.
Okay.
But, keep going.
The main reason I'm asking is just trying to find a solution for the health centers not to go outside of their EHR to get data. That's really the main pain point here.
Oh, yeah.
And so the way Care Quality worked with the EHR vendors to embed it into their EHR, that's a big key to their success. So just, some guidance for Eddie would be to do the same.
Well, I think that the conversation we will need to have is, or the tip of the spear for this will probably be OCHN. Because we're already live with OCHN, the OCHN FQHCs in Oregon. And now we're going to go live in California next week.
Well, you don't have that many. Good for them.
Just as a guinea pig, right? And then, right, that we kind of figured this out with clinics that are on Epic Ocean, and then how do we figure it out for clinics that are on Next Gen WCW?
Okay, one more question. Who do I talk to at LA Care for the sponsorship on Eddie? Who are you going to talk to? Who are you working with?
Right now, right now we can talk to Paul. Do you know Paul Stout, the HIU program manager?
Yes, I do very well.
So talk to Paul.
Okay, got it. Thank you.
Yeah, I'm sorry I have to run.
Well,
We just really, really appreciate it.
It's all right, we're actually at time anyway, so
Okay, great.
thank you so much for coming down, and thank you so much, Deb, for coming in and presenting, and for the rest of the team as well, and everyone joining. So we will go ahead and adjourn, and see you in 2 months. Bye, everyone.